Good morning, everyone. Thank you for coming. It's a great pleasure to present our speaker today, Dr. Maryam Shahi, well known to all of us. Maryam graduated from the medical school in her home country, Iran, where she also trained in OB/GYN, and then came to this country where she worked for 1 year as a research assistant at Howard University in Washington, D.C., and then joined our program for APCP, during which she devoted 1 year in cytology fellowship. Maryam has close to 10 publications on her CV, well published. She's a regular presenter in US CAP. This year she's also presenting some of the work she has done. She's getting great mentorship with many of our faculty. Just to name a couple in AP, Dr. Fatchen Lee and Dr. Khalid Amin are working with her, and I think you will see their influence on the presentation today. Maryam has a unique quality of an academic pathologist. She's always asking questions, and she's always asking the right questions. As a typical investigator, we could be discussing a very usual entity, and then she goes where nobody else goes, and then she starts exploring additional points. And I think she's an exemplary resident in our program and a role model for junior residents, and I'm sure you will enjoy her presentation today.
Thank you very much. Thank you very much, Dr. Khalifa, for your kind word. I didn't really expect that. Today I'm going to talk about 3 dimensions of thyroid pathology. I don't have any conflict of interest to disclose. The objectives of this talk include to illustrate the history and the involving nature of neoplasm nomenclature. And also, I want to briefly review the Bethesda system for thyroid pathology, thyroid cytology, and show how nomenclature revision reduces the risk of malignancy. Also, I want to briefly discuss the role of molecular diagnostic and the risk stratification of indeterminate thyroid cytology. And eventually, I want to talk about how intertwined relationship of molecular diagnostic, cytology, and histology is in thyroid pathology. Okay, let's start with histology. Based on review literature, the first description of thyroid pathology was described in 1811 by Alan Byrne. In 1844, Robert Roy tried the first classification of thyroid pathology based on growth pattern and consistency of the tumor. The first histologic classification was done by Cohnheim in 1876 when he tried to categorize thyroid tumors into sarcoma and carcinoma. What we know about papillary thyroid carcinoma was the attempt that Anton Wolfer did in 1883 and described a papilliform thyroid tumor. But it took 50 years to have the first classification of papillary thyroid carcinoma by Graham. Before 1960, most of the most thing that we knew about papillary thyroid carcinoma was the growth pattern, papillary growth pattern. However, Stuart Lindsay described the not specific but characteristic features of papillary thyroid carcinoma nuclei, which includes delicate nuclear membrane, sparse delicate intranuclear chromatin, folding and indentation, and also ground-glass chromatin appearance. As you can appreciate here, we have these enlarged nuclei kind of elongated with nuclear folding in form of indentation and nuclear groove, and you can appreciate the ground-glass appearance of the chromatin. However, the most important feature of papillary thyroid carcinoma, which is nuclear pseudo-inclusion, was identified by Gray-Doniak 8 years later after Lindsay described those features. And they did electron microscopy and identified the presence of these pseudo-occlusions as a result of invagination of nuclear cytoplasmic membrane into nucleus. as you can see it here, in H&E, you can appreciate the presence of these well-demarcated, smooth contour inclusions that they have margination of they have a condensed membrane because of the margination of chromatin. As I described, they should have the color and the consistency of the cytoplasm because it's actually cytoplasm invaginating into the nucleus, and it should at least occupy 1/3 of the nucleus diameter. The other feature that we all know about papillary thyroid carcinoma is optically clear nuclei, which is actually it's not a specific, it's not a biologic feature of this tumor, and in fact it's a processing artifact, as was shown by Louis Denner when he was at the University of Minnesota in 1979. Since pathologists love to use eponyms for every single item in pathology, they brought up a challenge and debate. So who should they name it after? So there was a challenge in 1971. Dr. Nathan Friedman from UCSF suggested to name this nuclei after Martha Scott Hudice. On the other hand, Nancy Warner suggested Little Orphan Annie eyes, and we all know who's the winner. So I want to point out, actually, Orphan Annie is a real character. It's named after Mary Alice Smith I think in 19th century. He was an orphan and he was raised by Riley family. And the son of that family actually found the character of Allie interesting and used her as her character for his poems. It was called Little Orphan Allie, but the publisher made a mistake and called it Little Orphan Annie, and that's what we stuck with. Harold Gray was the person who depicted this character as what we already know. This is a strip cartoon that used to publish in 40s and 50s, and all the characters of this comic strip they have empty eyes. So I don't want to discuss how hard and how difficult was for pathologists to categorize and classify these thyroid tumors. There were many attempts performed to classify them comprehensively, but as a result, I don't want to discuss all of those, but the last two that are the main classifications we are using currently are the third WHO classification published in 2004 and AFIP that was published in 2014. They are more or less the same, and the thing that I want to emphasize is actually to focus on variants of papillary thyroid carcinoma. There are 12 different variants of papillary thyroid carcinoma, but my main focus would be on these two categories: classic papillary thyroid carcinoma, which constitute 19% of all the variants, and follicular variant, which constitute 25% of them. They further categorize based on having capsule, being encapsulated, non-encapsulated, or infiltrative, and whether there is a capsular invasion or not. And the main focus of this talk is actually follicular variant of papillary thyroid carcinoma. Again, it was Stuart Lindsay who described follicular variant of PTC for the first time in 1960, but it was Dr. Rosa, his Search Path Fellow when he was at the University of Minnesota, who illustrated the features in detail. And the variant of encapsulated variant actually was described later by Schroeder in 1984. Papillary thyroid carcinoma, the classic type, as you can see, constitute of these arborizing papillary configurations. And as you can see, follicular variant lack these papillary configurations. However, if you look at them in high power, you can appreciate both of these variants have enlarged nuclei. They have nuclear overlapping, clear chromatin, and also they have nuclear indentation, elongation, grooves, and more importantly, nuclear inclusion, pseudo-inclusion. So, and that's not the problem, but that's the way that we diagnose papillary thyroid carcinoma, based on the cytomorphology of this lesion, not based on the pattern. So what we've learned about follicular variant of papillary thyroid carcinoma so far, we already established that architecturally they are follicular, and cytomorphologically they are papillary-like. And we also mentioned that there are multiple variants of it. We have encapsulated well-circumscribed, non-encapsulated well-circumscribed. We have encapsulated without capsular invasion, which we lump them together as non-invasive follicular variant of PTC. Also, we have not encapsulated with capsular invasion, and eventually we have infiltrative pattern that we lump these two as invasive variants. We don't have any problem to call these two a malignant neoplasm, because they already established their aggressive behavior by having capsular invasion or invasion to the outside of the thyroid. However, the problem arises with this category because we don't know what is the exact nature of these lesions, what is the biology underneath of these lesions. Do they behave, or how is the behavior of these lesions? Do they behave more like papillary thyroid carcinoma or follicular? To answer this question, I need to give you a very brief introduction to mutational analysis of thyroid carcinoma. I will discuss it further during my talk, but for now, we have two main mutations in thyroid tumors, BRAF and RAS. BRAF is the most common mutation identified in papillary thyroid carcinoma, and it has a very high, almost 100% specificity for this diagnosis. And based on literature review, we couldn't really see any follicular carcinoma or even or any benign thyroid lesion that harbor BRAF V600E mutation. On the other hand, RAS mutation is the most common mutation that we see in follicular lesions. With that introduction, there are multiple studies that I chose these two as an example. One study by Rivera in 2010 showed that the lesions, that the follicular variants of papillary thyroid carcinoma, if they are encapsulated, 36% of them harbor RAS mutation, and interestingly, none of them had BRAF mutation. However, non-encapsulated follicular variant of PTC shown to have some degree of BRAF mutation. In another study done by Hobbit from Brigham, she looked at partially encapsulated follicular variant of PTC. They were partially encapsulated but well circumscribed. And again, she showed that these lesions, they harbor, in 46% of cases, they have RAS mutation, and again, none of them had BRAF mutation. So to summarize what I've already shown in previous study, if we consider RAS mutation as a hallmark or a specific mutation for follicular lesions, and BRAF a common aberration in papillary thyroid carcinoma, encapsulated follicular variant of PTC is more similar to follicular lesions, whereas infiltrative follicular variant of PTC is more on the classic papillary thyroid carcinoma side. We also, I might also included multiple studies that evaluated the behavior of these lesions. Just to show you, attract your attention to this study by Baluch and Libolsi from UPMC, they looked at bone metastasis initially. And so they had 5 cases of papillary thyroid carcinoma with bone met. Then they looked back to the primary tumors and find out 80% of these tumors had capsular invasion. In another study, which the design is totally different by Leo, they looked at the primary thyroid tumors, all of them follicular variant, and they noticed that the encapsulated ones without capsular invasion had a very indolent behavior. None of them had any lymph node or distant metastasis. On the other hand, if they were encapsulated but had capsular invasion, 17% had lymph node metastasis, and some of them also showed distant metastasis. The infiltrated follicular variant of PTC, they only showed lymph node metastasis, and they couldn't really detect any distant metastasis in those cases. So again, if we consider lymph node metastasis as a characteristic, as a feature or kind of a characteristic behavior of papillary thyroid carcinoma, classic papillary thyroid carcinoma, and less common in follicular carcinoma, so we find out that encapsulated follicular variant of PTC behaves more like follicular carcinoma or follicular lesions. On the other hand, infiltrative follicular variant of PTC behaves more like classic PTC. So we can declare that encapsulated follicular variant of PTC behaves like follicular adenoma if there is no capsular invasion, because it behaves very indolent, in an indolent manner, and it looks like follicular carcinoma if there is capsular invasion, because they are prone to have distant metastasis. So we already established that encapsulated follicular variant of PTC has nuclear features of papillary tumors, but architecturally, mutationally, and clinically, they behave like follicular lesions. The problem arises when we actually manage these cases like papillary thyroid carcinoma. So there's a tendency for overdiagnosis of these lesions. At this point, there is no consensus criteria to diagnose them, so there was a very high lack of reproducibility of diagnosing these lesions. Okay, so let's answer a critical question. I already told you all of these information, gave you all of this information. So based on those, do we think that clinical outcome and mutational status of non-invasive encapsulated follicular variant of PTC warrants reclassification of this tumor as a non-malignant entity? Well, this question luckily answered very recently in last August. This study was done by a constellation of 30 pathologists, endocrinologists, surgeons, and biostatisticians, and they established a set of criteria based on architecture, molecular cytologic features, and lack of these aggressive behaviors such as vascular invasion, capsular invasion, tumor necrosis, or mitotic activity. So they categorized their cases into two groups, Group 1 and Group 2. Group 1 are the cases that fulfill the criteria that I just mentioned, so they are non-invasive. And Group 2 are the cases that didn't fulfill the criteria. And after a long follow-up time, they noticed that none of the cases that fulfilled the criteria had any adverse events. So among 109 patients with non-invasive encapsulated follicular variant of PTC, all of them were alive and with no evidence of disease at a median follow-up of 13 years. So they decided to change the nomenclature into non-invasive follicular thyroid neoplasm with papillary nuclear features, or NIFTP. So let's see what just happened. Before introduction of NIFTP, we had these two groups categorized as malignant group in taxonomy, malignant taxonomy. After NIFTP introduction, we removed these two and add them into benign diagnosis. So we are kind of reducing the rate of malignancy by just changing the nomenclature. This is great, right? We think that we are settled. We have established sets of criteria, and we can move on. But let's hold on to this question, and we will answer that. Second part of my talk is cytology. Cytology in thyroid is the first step in management of thyroid nodules. And to establish and unify the nomenclature, almost 10 years ago, there was an attempt to do this, to replicate the success of cervical cytology. Anyway, a group of people got together in Bethesda, Maryland, and they tried to have a unified nomenclature. They published their result in 2010 as a book that we all use now. They categorize the cytology specimen into 6 categories of non-diagnostic, benign, ATP of undetermined significance, follicular neoplasms, or suspicious for follicular neoplasm, suspicious for malignancy, and malignant. We don't have any problem really with non-diagnostic, benign, or malignant category because we all know how we should manage those. It's straightforward. But the problem is these 3 groups, AUS, suspicious for follicular neoplasm, and suspicious for malignancy, that we put them together as indeterminate cytology category because we are not quite sure how we should approach these cases. Bethesda system also provides us risk of malignancy for each category and the usual and optimal management for each one. The focus of this talk is not to go over the how we diagnose cytology, thyroid cytology, but I think it's worthwhile to mention how we approach thyroid cytology. So the first thing that we notice is adequacy. We want to make sure we have adequate sample, and if it's adequate, do we have a hypocellular specimen or hypercellular specimen? Second feature is architecture of the lesion that we are looking at. So we are looking for macrofollicles, which is a feature of the benign lesions. They are usually 2-dimensional structures. They are not overlapping, and they are kind of a big lumps of cells. We also look for microfollicles, which they constitute of 15 or less follicular cells arranging in a circular fashion. And also, we are looking for papillary configuration, which is a 3-dimensional structure, and sometimes we get lucky and see the fibrovascular core, and this is a characteristic feature of papillary thyroid carcinoma. The last but not the least is cytomorphology. We are looking to see if the cells are bland, they are round and regular, respecting each other borders, or they have features of papillary thyroid carcinoma, as I pointed out previously, which show nuclear enlargement, indentation, groups, dispersed and kind of fine chromatin pattern, and more importantly, nuclear pseudo-inclusion. I should mention that we cannot use optically clear or orphan Annie eyes in cytology. As I pointed out, it's a processing artifact due to formalin, so it's not applicable in cytology. So we talked about cytology, and we talked about follicular variant of thyroid cancer. Can we diagnose follicular variant of thyroid cancer by cytology? And if we can, how? So we already said that architecturally they are composed of microfollicles, and cytologically they have typical nuclear features of papillary thyroid carcinoma. Based on our institutional experience, we noticed that most of these cases fall into ATP of undetermined significance, suspicious for follicular neoplasm, suspicious for malignancy, and rarely we diagnose them as positive. Very rarely though. But after the change and revision of the nomenclature, how does that affect on thyroid cytology and our result? So we conducted a study. We looked at the impact of new nomenclature of NIFTP on reporting thyroid cytology. For that, we extracted all the cases, all the thyroidectomy cases from 2010 to 2015, to be able to assess the rate of malignancy reduction in each cytology category after application of NIFTP nomenclature, and also to see what are the main cytology categories that were affected after this nomenclature revision. I just showed you, previously showed you this diagram, but I want to point out, again, we are excluding these two categories from malignant taxonomy and add them to benign neoplasm. So we have a corresponding reduction in the rate of malignancy. So we are looking for that reduction. As I pointed out, we looked at all the thyroidectomies from 2010 to 2015. We were able to exclude 177 cases just based on co-path review and synoptic review because they clearly showed invasive behavior. So we ended up reviewing 309 cases that possibly could fall into NIFTP diagnosis. We applied the sets of criteria that that were established by JAMA, the JAMA article, and we used this supplementary data that they provide in their supplement as our visual guide how to score the nuclear features. As a result, we identified 30 cases fulfilling the criteria for NIFTP. Then we looked at the cytology diagnosis of these cases, and we noticed that the vast majority of these cases fall into indeterminate thyroid cytology. We also looked at the original histologic diagnosis of these NIFTPs, and sure enough, most of these cases were diagnosed originally as follicular variant of PTC. But as you can see, 30% of cases had other diagnoses, such as follicular adenoma, Hashimoto thyroiditis, and nodular hyperplasia. So at this point, let's do an exercise. Okay, I need to point out, after application of NIFTP, we saw 7% reduction in the rate of malignancy in our thyroidectomy specimen. So let's do this practice. I'm going to show you 3 pictures that all of these cases diagnosed as NIFTP. Can you guess which one of these was originally diagnosed as follicular variant of PTC? Just you can guess. Just want to show you how difficult it is to predict if we just notice the architecture. So as you can see, this case was the only one that diagnosed as follicular variant of PTC. This Hashimoto case, this is a nodule here, again, to some extent show nuclear features, papillary nuclear features. And this is a follicular adenoma, which again fulfills the criteria for NIFTP. In literature review, I found 3 other studies that they were trying to exclude non-invasive encapsulated follicular variant of PTC from malignant category and look at the effect of that on their Bethesda categories and system. However, it was before NIFTP introduction, and I think our study design has a superiority because we looked at all the glass slides. However, these cases just looked at the synoptic reports and they didn't really go over the slide review. So they noticed the most effect of reduction, cancer reduction in suspicious for follicular neoplasm category. However, we identified that AUS was the most affected group, followed by suspicious for follicular neoplasm. So, as I pointed out before, we have most of these cases, most of the NIFTP cases fall into one of these 3 categories: ATP of undetermined significance, suspicious for follicular neoplasm, and suspicious for malignancy. We don't have any problem really if we put NIFTP in these 2 categories because we either repeat FNA or, maximum we do lobectomy. But what's going to happen if we put these NIFTPs in suspicious for malignancy, or even worse, if we diagnose them on cytology as positive? So we are going to do total thyroidectomy when it's not necessary. So how we should manage a possible NIFTP on cytology and avoid overtreatment? Let's have this question again in our mind, and then we come back later. Now I want to move on to my third part of talk, which is molecular. 70% of thyroid cancers harbor mutations in form of point mutation or gene rearrangement. The most important mutations that I already mentioned are BRAF and RAS. BRAF mutation is the most common alteration in thyroid papillary carcinoma, which happens in 40 to 50% of cases. It has a very high specificity, and we never have any report of follicular carcinoma or any benign thyroid lesion that harbor BRAF V600E mutation. It also has prognostic implications because these tumors tend to have aggressive behavior and less responsive to radioiodine ablation. Also, there are some trials that they are talking about using this BRAF as a target for treatment by seronafib. There is a very rare mutation in BRAF category, which is not V600, but it's K601E, and it's found to have association with follicular variant of papillary thyroid carcinoma. Also, it's worthwhile to mention that BRAF is associated with variant of papillary thyroid carcinoma, where we can see in a more aggressive type of papillary thyroid carcinoma, which is a tall cell variant, 80% of cases harbor BRAF mutation, as compared to follicular variant that only 10% of them have BRAF mutation. RAS mutation, in the other hand, is the most common mutation seen in follicular pattern tumors. And also, there are some reports that we can see them in even non-neoplastic lesions. Some studies mention that it can be associated with metastatic spread and the differentiation of these nodules. But for the most part, the most important thing is that we appreciate their presence in follicular pattern tumors. So how molecular diagnostic actually helps us to do risk stratification of indeterminate thyroid cytology. If we have either of these categories, AUS, suspicious for follicular neoplasm, or suspicious for malignancy, the management the recommendation, I should say, is to perform molecular diagnosis. And if any of these mutations come back positive, the risk of malignancy is that high that warrants total thyroidectomy. And if we have no mutation, we can perform a less aggressive management. We performed a study and we looked at our data. We tried to correlate the histology and mutational status of our lesions in 2 years. So this article was published this year in Thyroid Journal. And just to give you the summary of the result, so we identified that being negative for mutation is a reassuring fact that we can predict the benignity of nodules, because we had a very high negative predictive value. And also, by having a positive mutation, we could argue that we had 15% increase in rate of malignancy in AUS and suspicious for malignancy categories. In another study, we also looked at the mutational status of NIFTP cases. We had 99 surgical specimens with available mutational status. 11 of them fulfilled the criteria for NIFTP, and 8 of them, 73% of them, had mutation. And it's not a surprise that I say most of these cases had RAS mutation. But more importantly, none of them showed any BRAF V600E mutation, which is in keeping with previous findings. There are multiple commercially available tests. Afirma is one of them, which is a gene expression classifier. It has a very high negative predictive value. And the other one that is, oops, too soon, more commonly used is a Thyroid, which is a next generation sequencing test. And it has a high negative and positive predictive value. We also have we have an NGS-based test in-house, which we can identify. We are looking for, I think, 5 mutations, 5 most important mutations in thyroid lesions. And what you can see, the problem with these tests, all of them are very expensive. Actually, our price is surprisingly lower than what we see in commercially available tests. However, since 2015, these tests actually were declined to be reimbursed by insurance company, which is a problem. And now we are stuck how we should manage these indeterminate categories. Is there a new horizon? Can we predict molecular aberrations by cytologic features? And for that reason, we performed another study. We looked at the correlation of cytomorphologic features and mutational profile of thyroid nodules in indeterminate categories. So in that study, we had over 1,000 thyroid nodules. We had 250 indeterminate cytology results, and we sent 228 of them to UPMC to perform Thyroid. And among those, we had available results in 189 cases. So we pulled out these 189 cases, reviewed the slides by 2 pathologists, blinded by the mutation of the status of the mutation, aberration, or histologic result, and we evaluate them for different cytomorphologic features, including cellularity, architectural features, cytoplasmic features, nuclear features, and extent of ATPR, and also colloid. We did a semi-quantitative analysis by a scoring system. So, for example, for cellularity, we gave a score of 1, 2, 3. 0 is not applicable because all of the cases were adequate that entered the diagnosis or entered the study. And so, for example, for microfollicle, we had 2 scores, less than 30% and more than 30%, and so on. And to summarize these cytomorphologic findings, we used both a 2-tier and 4-tier ATPR score system. So we kind of extracted all the information from this scoring system and summarized them in these 2-tier and 4-tier scores. We performed statistic analysis, and we noticed that these cases, actually, the result was cases with mutation were significantly associated with higher scores in cellularity, cell ATPR, enlargement, and all other. And as a result, they had a significantly higher ATPR score in both 2-tier and 4-tier system. We also looked at each individual mutation, and more importantly, BRAF and RAS. And as you can see, BRAF, again, shows a very significant, statistically significant difference and correlation with the ATPR. RAS also showed the same finding, but maybe a little bit lesser than BRAF mutation. Also, I need to emphasize that presence of RAS mutation was associated with higher microfollicle score, which we already know. It's a no-brainer, but yeah, we verified and validated that. So the take-home message of the study was that indeterminate thyroid cytology cases with higher degree of cytologic atypia have significantly greater incidence of BRAF and RAS mutation. And we can claim that by utilizing a scoring system, we potentially can decrease a number of indeterminate cases and perhaps the cases that require mutational analysis. So I hope at the end of this talk, you all agree that the histologic classification of thyroid tumors continue to evolve, aided by molecular evaluations of this lesion. Cytologic evaluation, histopathology, and molecular diagnostic all provide complementary information about the nature of thyroid tumors. And the score-based cytologic evaluation, in conjunction with prudent molecular testing, can provide financially and diagnostically optimal results to the management of controversial thyroid lesions. Also, I think that this model of approach diminishes the indeterminate cytologic result, clinical overtreatment, psychologic and financial burden on the patient and healthcare system. And I think it's really important to say that evidence-based practice over expert opinion practice is highly appreciated and warranted. And by that, I want to thank you, my mentors, Dr. Amin, Dr. Lee. I cannot thank them enough. I also want to thank my pathology advisors, Dr. Snover, Manival, and Dr. Nelson. Also, clinical advisor, Dr. Lynn Burmeister, who came here, and thank you from all the team members who helped me in different aspects of this study. These are some of my references, and by that, I'm ready to take your questions. Yes, please.
So I have a question.
Sure. Please go ahead, Dr. Linda.
So just about the recategorization from non-invasive carcinoma. So I mean, it seems like one of the biggest clinical problems is that when you present with a thyroid disease, you can ask for it and you kind of determine the potential, and then someone goes to thyroidectomy. And usually if it's benign, that's good for the patient, but it adds a morbidity of having to take thyroxine for the rest of their life.
Exactly.
So I really like your study. It was really well done. But by first starting with the thyroidectomy specimens and looking back, you're missing a lot of unsampled lesions. So I'm curious, have there been any autopsy studies to kind of just look at what is the incidence of non-invasive follicular variants or papillary thyroid?
That's a very good question and point. And actually, no, I totally understand. And in fact, it's kind of hard to, to be honest with you, I didn't really see any autopsy study looking at this. I think there are some reasons for that. So basically, after the fact, patient is dead, and there is no interest to perform a $4,000 test on a case like that to see, for example, what's the molecular status of it. But on the other hand, I think it's a fairly new entity, and that's why there are not that many studies looking at this. And I think that's a novelty of our study. Basically, we can claim that we are one of the ones, pioneers in this study. So, but that's a very, I think, good observation, and I totally agree with you. Oh, sorry.
Very nice talk, Maryam. Is NIFTP a pre-malignant condition?
So based on molecular status, we didn't see any BRAF mutation in these cases. And RAS mutation, there are some studies that, as I pointed out, there are some cases that they are saying that they are prone to have dedifferentiation or lymph node metastasis. Based on the follow-up data that we have, I think 13 years is a long time to study these cases. And after 13 years or more, we didn't see really any cases that metastasize or have mutation. But potentially, yes. We never can say they are not pre-malignant. But based on our behavior study, we can claim it. We can say no. Yes, please.
So in melanoma, these are common mutations, BRAF and RAS. And in that case, they're mutually exclusive. There's one or the other, not both.
Sure.
Never, but usually not. Is that the case here?
So basically, in thyroid pathology, it's not completely, it's not completely mutually exclusive. There are some cases, there are some studies that a BRAF or a RAS mutation can harbor additional mutation like BRAF, and they tend to behave worse.
That maybe it's two lesions, but the large data, it is the RAS and BRAF are mutually excluded, but you can have additional other mutations. But sometimes they are hybrid lesions. But usually it's a mutual exclusive, right?
Yeah, they tend towards mutual exclusivity if they're isolated lesions. As Fachin brought up, it's always very difficult to tell in the thyroid if you have a collision of an adenoma with a papillary carcinoma or something like that, in which case, depending on how you sample, the fact that you're grinding up an entire lobe and throwing it in that NGS machine, you're going to see both mutations. And then, yes, PI3 kinase mutations are associated with progression, P53 mutations are associated with progression. So there's a whole host of additional markers that go on if you get to a higher grade of thyroid carcinoma.
I have a comment. Actually, amazing is doing very good. 5 years, we only put 30 patients into a malignancy category. But if you look at the institution, they probably put some, maybe put 1,000 people in a malignant category. Even the expert, because we have cases being reviewed by other experts. They call the patient 81 years old, even for 30 years follow-up and nothing, converted into a follicular very tough content, but actually it is not. So it's actually not a problem in our institution, but it's pandemic in some other institution. I think people has experienced that too.
Yes, please.
Did your studies trickle down to our clinical practice? Did you see
The
us now, after all of these analyses, change the way we report them, or maybe add a comment about the correlation with molecular?
I think it's a very critical point. This is a very fairly recent introduction. And I think we are all very curious to see what's going to happen in this use gap and how people are reacting to all this information, recent information. So I should say at this point, and Dr. Bermeister can second me if I'm wrong, can support me. I don't think at this point we are doing anything differently, but these are the possibilities, these are the change in management that we possibly can apply in our system.
So when you come back from San Antonio and write these manuscripts and they get published, then we can cite these references in our report.
Hopefully,
right?
yes.
As pioneers, as you said.
Any other questions? Thank you very much.